Renew, happy Friday evening to you.
Happy Friday evening, middle of summer. It's still holiday mode in Australia, isn't it?
It certainly feels like it. It's hot outside Friday evening.
Yeah. 2 days ago there were thunderstorms, but today it's hot outside.
It's 34. The tennis is starting. It feels like the great Melbourne summer has finally arrived.
Everyone's out and about. It's a good time.
Yeah.
Definitely.
And today, though, we're going to actually go back in time a little bit, back a few months.
We are, because we're going to go back in time to revisit your trip to Milano and San Raffaele University, a fantastic place. We have very good relationships with all the guys there, steeped in tradition, and we're going to hear about your trip.
Yeah, so I was passing through Milano a couple of months ago. I was invited as visiting professor, which was a real honour to go to that particular place, because I've been to Milano before, but not to San Raffaele University Hospital, which is a very famous place, of course, in urology, to see Professor Monitorsi and team up there. And I had a really good time. I did some talks, but they did some amazing talks, updating us on some of the work that's coming through that we'll probably start seeing at EAU, and about some of their most recent papers. But there were a couple of things in particular that struck me, and I thought what we should do on this podcast is go and focus in on areas that we're very interested in. And this is going to be about pelvic lymph node dissection, PSMA PET, who needs a lymph node dissection, topics like that are really, really topical day to day for us, those of us who do a lot of this type of work. And also coming up later in the podcast, I did get a chance to sit down with Professor Francesco Monitorsi, who's been the chair and head of that unit for, I don't know, a couple of decades maybe. Right? He really built it from a really quite a small place, a really good place it was with Professor Briganti, but we chat to him about how that place developed, but also some really interesting perspectives on things like prostate cancer, on training and stuff like that today. So that's coming up later in the podcast.
It's going to be great. Tuned. And Francesco's still going strong, isn't he? He's amazing.
Yeah, he is amazing. And of course, you went there.
I was there too. Yes.
When was that?
That was just after. No, it was the year before.
Yeah,
it was the year before the EAU in Milano.
That's
fantastic.
Right. That's right.
Yeah.
And you stayed on and you were visiting professor.
Yeah.
So thanks to our friends at San Raffaele. It is a great place.
Yeah.
And
fantastic hospitality and good friends of ours. So even though this is a topic that we sometimes go back to, the role of node dissection in prostate cancer, the Briganti nomogram is famous, and I'm really impressed that the team have thought to update it, given the newest technologies out there.
Yeah, so it's great to invite Dr. Giorgio Gandaglia, a urologist at San Raffaele, to join us on the podcast. Friend of ours, friend of the podcast. Giorgio, great to see you.
Buongiorno, Giorgio.
Hi, good evening.
Look, it's great to see you. Thank you for joining us from a Friday morning in Milano. What's the weather like there?
Very cold, like 5 degrees or something like this. No snow, but it's cold.
But it's Milan, so it doesn't really matter.
So we invited Giorgio on because he's been very involved in much of this work.
First author of this paper in European Urology Oncology in December, in the December issue. So a fantastic paper.
Yeah, and also, and we'll put the links up in the show notes, this is a paper entitled Identification of the Optimal Candidates for Node Staging with Pelvic Lymph Node Dissection among patients who underwent a PSMA PET-CT. And on the background of this is your team also produced a very nice systematic review in European Urology Oncology last year, looking at the role of PSMA PET in identifying patients. So that's the background. That's what we want to pick your brains on, Giorgio. Your team did some superb presentations when I visited there a few months ago, and we'd love to dive a bit deeper and learn your thoughts. So do you want to talk a bit about these papers?
Yeah, take us through.
Yeah, thank you for this invitation. And I believe this is a very hot topic in urology, even though you already said that you discussed extensively the role of pelvic lymph node dissection, but still we know that pelvic lymph node dissection is a procedure associated with increased operative time, increased risk of complications, and risk of readmission. Therefore, we try to limit the number of dissections we are performing, and the introduction of novel imaging modalities such as PSMA, PET-CT, or PET-MRI changed the way we stage preoperatively our patients. Nowadays, we have virtually all patients, even intermediate risk patients undergoing surgery in a San Raffaele hospital, will receive a PSMA PET-CT. And this might change our surgical approach, and it can have an impact on the decision to perform a pelvic lymph node dissection. So our idea, and we started actually, as Declan said, from a paper by Armando Stabile. It was a systematic review of the literature, and he was able to demonstrate that the negative predictive value of PSMA PET substantially changes according to the baseline LNI risk. So patients with a higher risk disease and a higher risk of LNI are the ones where the negative predictive value is lower. So they are the ones where we somehow cannot rely on a PSMA PET. And why is it? Because basically we know that the majority of patients, we're talking about 60% of men with lymph node invasion have a macrometastatic disease, lymph nodes which are metastatic, and the metastases are smaller than 5 millimeters. And these metastases are typically missed both by conventional imaging and by a PSMA PET. So we want to identify those men, and we want to be able to, say, perform a lymph node dissection in patients with macrometastatic disease and with lymph node invasion. If you use the oldest version of the nomogram, the Briganti nomogram, you realize that you are performing lymph node dissections that are, let's say, so-called useless dissections, because in 80% of the cases, you don't have positive nodes in your template. So basically, these are procedures which are exposing the patient to an increased risk of side effects, complications, and which are also costly for the healthcare system and time-consuming. So we want to avoid and to reduce this rate of PN0 patients. Ideally, we should perform a lymph node dissection only in patients with lymph node invasion, and our models should be able to reduce the rate of false negative findings. So that was our idea, and we wanted to test the role of PSMA PET in selecting patients for a lymph node dissection, and we wanted to test the characteristics of our models in the PSMA era. So we started from a population of patients who were staged with PSMA PET. And we used an approach which was different from what previously done by other authors, because we decided to focus on patients with a negative PSMA PET. So we did not want to include patients with a lymph node uptake at the PSMA PET, because we believe that everyone would, if you select this patient for a surgery, you will end up in performing a lymph node dissection, because you know that there's something in the pelvic nodes, and you want to try to maximize the role of surgery. So we decided
because we know that if the PSMA PET is positive for nodes, it's pretty much always right. That's the. I mean, there may be more nodes than you see, but I presume it's because the specificity is very high. If there are nodes on a PET scan, it's almost PN1. So that doesn't add as much value. What we're really interested in is if the PET scan is negative, can we avoid a lymph node dissection? What is the negative predictive value? So that's why you chose the population of patients that are negative. And this is both intermediate and high risk patients?
Yes, it is. Obviously, the proportion of patients with high risk is higher in this specific setting compared to what previously published in our nomograms, which did not include patients staged with PSMA PET. And going back to your point, Declan, actually we had a debate at the last EAU meeting on the rate of false positive findings at PSMA PET. And as I told you, in our series, we have a multi-institutional series including approximately 1,000 patients, and the rate of false positive findings in the pelvic nodes is not negligible. We have like approximately 15 to 20% of false positive findings, which is substantially higher compared to what reported in other studies like randomized trials, but it reflects the real life scenario. So it's something that we should also consider when you are dealing with patients treated and staged and receiving a PSMA PET everywhere in the world. In the real life, it might be that the rate of false positive finding is slightly higher compared to what previously reported by high volume referral centers like yours. That being said, going back to our study, we basically wanted to include only patients with a CN0 or rather MIN0 disease at PSMA PET. And starting from there, we wanted to see whether the use of nomograms could improve our ability to reduce the number of useless pelvic nodal dissections. So basically, we validated the available nomograms, which include the Briganti nomogram and the MSKCC nomogram. And we realized that these nomograms were associated with a really high rate of PN0 disease at final pathology in patients preparatively staged with a PSMA PET, and then we developed our novel nomogram. And if you see, and if you have a deep look at the nomogram, you realize that we are basically restricting the use of pelvic nodal dissection only in patients with a very high-risk disease. So it might be that you have a high-risk patient with high number of positive curves, but without SVI or extracapsular extension at multiparametric MRI. And in that case, the patient would probably skip a lymph node dissection. So you don't need to perform a nodal dissection, because in that case, the risk of missing LNI at final pathology is lower than 2%. And obviously, you have to adopt arbitrary cutoffs when you decide whether to perform a nodal dissection or not. And we tried to use the same cutoff, which are generally accepted by the guidelines. So if you look at the guidelines, they tell you to use the 5 or 7% cutoff, knowing that using that specific cutoff, you risk to miss approximately 2% of positive nodes. So not performing a nodal dissection in patients below that cutoff means that you are missing 2% of positive nodes. And we believed this was acceptable or considered acceptable by the urological community, and we relied on the same approach. And basically, using our nomograms, you can now, the novel nomogram, actually, the novel Briganti nomogram, including information obtained at PSMA PET and MRI, you can now avoid approximately 60% of nodal dissections, which is substantially higher compared to the previous versions of the nomogram. But what about Australia? Are you still performing, are you still performing a nodal dissection in some cases, or when you have a negative PSMA PET, you completely, let's say, forget about it and you go for the prostate and that's it?
Yeah, I mean, we've moved away from that a long time ago, didn't we? You know, for patients with a negative PSMA PET, we would seldom do a lymph node dissection for all the reasons that you mentioned.
Yeah, I totally agree. It's if it's negative, it is, and I suppose because it's been in routine practice in Australia for so many years to have PSMA PET CT, it just got embraced, and I think we understand that, of course, that means some men will miss a PN1 diagnosis if we did a lymph node dissection. But the next question that flows from that, maybe we'll throw it back to you, is, yeah, but does it really matter if you miss that 2 millimeter lymph node? You know, is it worth having, you know, so many patients go through the node dissection to find the one? Because although this is really good news, because it's reducing the number of men who, if you otherwise followed the guidelines, might have a very high chance of a negative lymph node dissection, therefore zero chance of any sort of benefit, and the risk of having a complication. But then on the back of our minds is still, well, even if you find the PN1s, there's really no evidence that it's going to improve their survival. So what happens in Australia then? Well, it's you don't do lymph node dissections pretty much. Very, very few people do. And patients are very well informed. They will tell us that they will ask about lymph node dissection and they'll have concerns about complications. Because if you don't do the lymph node dissections, what happens? Yes, there is always a biochemical recurrence rate, lymph node dissection aside, and then a PET scan may well find some pelvic lymph nodes, and then pelvic radiotherapy may deal with those lymph nodes.
So and I think in conjunction with that, the studies that look at just radiating the lymph nodes rather than radiating the prostate fossa will also be really interesting and will help that case go forward, really.
Yeah, which actually is Pete Ost is it Astro or Astro this year is reading out that case study on that question of, do you need to radiate the bed if the bed is not...
That's where the morbidity is. And if you can just radiate the pelvic lymph nodes, then what do you have to lose?
So I think we're at the other extreme, Giorgio. We're at the extreme of pretty much nobody gets a pelvic lymph node dissection. We do them on trial. We did them for the lutectomy trial.
The last time we did them, actually.
Really,
lutectomy trial.
So is the best approach somewhere in between? And does this paper help do that? Because you yourselves acknowledge that coming out of centres in Europe that have been very, very big proponents of pelvic lymph node dissection, You yourselves acknowledge that a lot of people have a futile or useless pelvic lymph node dissection, and all they get out of it is the risk of a complication. So do you think this data that might spare 60% of people from having exactly that experience is good, or should you be thinking of going even further to like what happens in Australia? Because we probably need to move back a bit. And I think, PSMA radio-guided surgery, another lovely paper of yours recently, maybe that's fills the gap between no lymph node dissections and too many lymph node dissections.
Yeah, I agree with your point. We still miss data telling us, level 1 data at least, telling us that performing a nodal dissection improves survival. So from one side, one will say, okay, we now have a PSMA PET that can be used also as soon as the PSA starts rising. So it can be used early postoperatively, and you can perform all what we know to improve at least biochemical recurrence-free survival or ADT-free survival, as demonstrated by the STORM trial and other trials in this setting. So metastasis-directed therapies. At the same time, we should acknowledge that the information on the presence of a PN1 disease can somehow guide you through the correct administration of adjuvant treatments. And this is true based on data which were obtained in patients who were not staged with PSMA and with MRI. So it might be that also this information cannot be replicated in contemporary patients. So the question is, should we perform pelvic lymph node dissections at all? We need randomized control trials, and these trials should also acknowledge the results of PSMA PET before surgery. So you need to use it as a selection criteria. Otherwise, you risk to have studies that cannot be applied to contemporary patients. And going back to your point, regarding the use also of radio-guided surgery, this is an interesting approach, and we are happy with it, particularly when the PSMA PET is positive. So when you see something at preparative imaging and you use radio-guided surgery, that can guide you through the complete removal of a node which is, for example, outside of your anatomical template, or which is difficult to reach. Sometimes even if you perform an anatomically defined pelvic lymph node dissection, you might miss something, and the use of a gamma probe during surgery can assist you. We still have doubts regarding its role to avoid a nodal dissection. So if you don't have an uptake using the intraoperative gamma probe, and the patient is a very high-risk patient, at the time being, I would still remove the nodes, because it might be that the spatial resolution of the probe, which is approximately 3 millimeters, can miss some micrometastatic disease. And if we think about the concept of micrometastatic disease, we realize that these are the patients that probably will benefit the most from a complete removal of the lymph nodes and of the metastasis. If you have a patient with a locally advanced disease and one tiny positive node of 3 millimeters, for example, and you completely remove it, these are the patients, according to our data, but also according to the MSKCC series, that can be free from additional therapies, adjuvant therapy, salvage radiotherapy, ADT, for a long time. So these are the patients that are more likely to be cured by surgery alone. So,
but the also question is, if you never did surgery on some of those lymph nodes, they might still not have any additional treatment for years. If you miss that 2 millimeter lymph node, it might be the same thing in a parallel universe. They do fine. Just sits there. It's active surveillance of a 2 millimeter deposit. So we can't actually say that with confidence either, just because it happens that if you have 2 or less PN1, turns out they do very well. But you don't know that the surgery made a difference.
They wouldn't have done well anyway.
So that's why I think, and you're right, there are the 2 big ongoing randomized trials at MSK and at Hamburg in the Martini Clinic are testing whether lymph node dissection versus no lymph node dissection makes a difference to not the PN1 but to the biochemical recurrence rate. So I think they're the 2 trials that you're referring to that we're all interested in. And have you, what do you think? Do you think that it's going to show a pelvic lymph node dissection improves biochemical recurrence in all comers? This is the PN1s and the PN0s.
I don't think they will prove a survival benefit.
Get a nice smile.
Wow. And
let's say I mean, you always need very long-term data, because if you include
Georgia,
everyone,
can I ask, in those patients who had a negative PSMA PET but had PN1 disease, did you stain those lymph nodes for PSMA? Did they stain positive for PSMA?
yeah, we did. We did it in the context of the trial Declan was mentioning. And what we realized is that when you miss a node, typically, at least in our center, is not because the metastasis is not expressing PSMA, but it's because of the dimension of the metastasis. So that is the driving force leading to a false positive finding both at PSMA PET before surgery and at the intraoperative evaluation. So we have an abstract that has been accepted at the EAU, and we have approximately 40 patients, and all of these patients were evaluated using immunohistochemistry, and we evaluated the PSMA expression both at the level of the membrane and it was basically, yeah, the dimension of the node is what really matters.
So the PSMA PET's not picking them up because they are, well, just like we said before, just very tiny foci of disease.
And that's why this work is very nice, and it really does help. And congrats again to your team and the collaborators you have on this more recent paper. We'll put them in the show notes, so please go and look at them. It does help us here in Australia, where PSMA PET is in widespread use, to think again about whether just blindly not doing a node dissection because the thing is negative is helpful, because this is the first time we've seen data that accounts for that a little bit as we try and work towards who is most likely to benefit, and the truth is probably somewhere in between. But my gut feeling here in Australia is that we won't be for changing very much.
Yeah, it's hard to go back, isn't it?
And actually, at the EAU this year, Georgia, I know we discussed it last year, but in a couple of months' time, I'm in a plenary arguing against the road of pelvic lymph node dissection. I can't remember who I'm up against. I'll have to look.
Is it you, Georgia?
It's not you, is it?
No, it's not me this time, because last time you won. So
I don't think I won. But I'll have to look it up and see who it is, and I'll be as usual in preparing for these debates. First of all, go for character assassination. So I'll have to find out who that is, and he or she will undoubtedly be preparing in the same way. It's very easy to make fun of me. But look, thanks so much. This is really nice.
If I may add something, Declan, just one
Yes,
sentence. The manuscript and these analyses have been recently externally validated. So if you look at the manuscript, you have an internal validation, but actually we were able to externally validate it and to compare with available nomograms, and it will be published soon. But what I can anticipate is that also the results at the external validation are consistent with what was obtained at internal validation. So we can rely on this recently published model to select candidates for an extended pelvic nodal dissection.
Let me ask you lastly then, if you're seeing a patient this morning in clinic who is a newly diagnosed 64-year-old gentleman with unfavorable intermediate risk prostate cancer, his PSA is 10, he's 4+3, straightforward looking cancer, he's had a PET scan, there's some avidity where the cores are positive, but he's N0. Will you offer him a pelvic lymph node dissection, or what will you say to him?
No.
Nope. Okay, so that's a big change.
There you go. That is a big change.
That is a big change. That's not what you and your team would have said it'd be in the pre-PSMA. So that's great to hear. I mean, listeners to this podcast, I think, will be interested in that, in coming out of not the Australians who are very cynical about lymph node dissection, but out of institutions that have real pedigree in this work. So that's good to hear. I'm chuffed with that.
Yeah,
that's good. Great. So look, thanks so much, Giorgio. What we're going to do for the rest of the podcast is we're going to cut back to Milano, when I was there a couple of months ago, and I got to sit down with Professor Francesco Monitorsi and have a chat about their institution, how they built it up, but also some really good questions from a person who has a lot of experience and has seen a lot of change in urology about some of the hot topics in prostate cancer. So Francesco, thank you for joining us on this special episode of GUcast. It's so nice to be here in San Raffaele with you.
We are delighted to have you here, visiting us.
It's a huge honor for me to come to this world-famous urology institution that you've developed over the past 20 years.
That's too much, but all our fellows and residents, they are eager to watch your slides, and we're listening to you tomorrow, so I'm delighted to be here today.
Me too. So I'm here as a visiting professor at San Raffaele, and I'm going to be delivering some lectures, but the best bit for me is I get to hear from all of the staff and the residents about the ongoing research. And of course, over the past 20 odd years or so, we've seen this huge growth of San Raffaele as a world famous urology institute. Can you just reflect a little bit on the growth? I'm sure it wasn't always what it is today.
Yeah, you're right. I would like to say that my boss and mentor, Professor Briganti, started the whole thing in 1985. I was born in 1962, so I was 23, and I started working with my mentor on that very year. So initially that was a non-academic unit. Professor Briganti was still alive, doing fine, very active and energetic. He was indeed a visionary person, and he was really able to see through the future and understand where the field would go. And he did all he could to transfer this capacity to ourselves. So I was very lucky to start with. And the group that he put together was a group of very talented individuals, and we were all excellent friends. Then, when Professor Briganti retired, I was honored to be placed in his position and his successor as professor and chair at San Raffaele, but I had already started in doing all I could in the area of research, which was always in my heart, although at those times it was very at the beginning, and so indeed we did not have all the knowledge that we would have today. And when the university started at San Raffaele, that was at the end of 1996 or 97, as a private university we started having students coming over, and clearly that changed things. So I'm sure that you're going to interview Alberto Briganti. He was a student with me. And so this is just to make one single example to tell everyone that if you have the opportunity to gather together a group of excellent individuals, then results will be there. And I hope that my legacy in the future will be that we are a good group of people, very young, enthusiastic, and we want to change things. And we try to, like you do in Melbourne, to do all we can every day to improve how we treat our patients and to leave trace of what we do. And I always tell my young residents that you must learn everything from guidelines, but I want you to know that you can change the guidelines yourself, because that should be the standard. I want to produce a research which is able to guide the others, to give a humble contribution, but that should be the direction that we should have. And I was very lucky.
I think so, and what a great legacy, you're right, is to say you've done some great individual things yourself, but isn't it that you build a foundation for ongoing research? And I must say, looking at the staff you have and the output from San Raffaele, it's incredible. It's a great team.
Indeed, what we would like to reach as a target today would be to be able to build up, and that would be the very first in our country, a multidisciplinary GU institution where, in my opinion, urologists should be the lead. But then we should have all our colleagues working with us, so radiation oncologists, medical oncologists, and nuclear medicine experts, radiologists, and so on. Because if nowadays, at the various different disciplines, clearly someone who wants to be in the field of GU pathology, he or she must be concentrating on that thing only, if you really want to be at the top. So it would make sense to be able to have a group only devoted to GU things. It's not easy, because also, as we all know, and in every country is different, there are rules that have to be followed. I'm thinking about administration rules, reimbursements, and so. But this is what we have in mind, and hopefully we will be able to put that together in the next future.
And you know, the nature of the GU oncology multidisciplinary team is changing, and compared to what it was 10 years ago to what it is now. And of course, nuclear medicine, as you mentioned, is the classic example.
And you guys are the leaders in Australia.
You know, and I remember it's not that many years ago, 8-9 years ago, when nuclear medicine had no interest in us as the GU oncology clinical team. And to be honest, we had no real interest in them. There was such little to offer. But fast forward to where we are now, but it's not an automatic relationship that suddenly your multidisciplinary meeting or your clinics or whatever will suit nuclear medicine, for example, to be involved, and vice versa. So have you been integrating new teams like nuclear medicine into the geo-oncology stream as these imaging and theranostic agents are coming on?
We have been, the group was really sure that we could be good as you want, but without colleagues in the other areas, we would be no one. So several years ago, we started working within the university to have the best pathologists working with us, the best nuclear medicine expert working with us. And so we really wanted the top people to come over to San Raffaele and give their contribution. And I have to tell you that now we have an excellent pathology unit dedicated to GU. We have probably the top nuclear medicine expert in the country, Arturo Chiti, now working with us, who left a very prestigious institution to be at San Raffaele with us, and we would have many examples like those. And indeed, the motor of the engine of this thing have been those working with me, not really myself, because now they are really the engines who are pushing the ship towards at great velocity. And the group made the whole thing. But yes, we are working as a group with others.
Because that's just an example of how something that we take for granted now, that value of nuclear medicine is clearly established in 2023, but 10 years ago it wasn't.
Well, as an example, Declan, my boss, Professor Briganti, was still there in the, I think it was 2001, 2002. We had a very strong nuclear medicine department at San Raffaele, and so they were the first in the country to have PET scan, and that was PET choline scan, and so he would use PET choline in evaluating patients with a relapse after a radical prostatectomy. So there is an historical abstract. First name Vincenzo Scattoni, working with us still today, and but the idea was coming from our boss, where we did use that tracer to study those patients. And that was the first step along the road of salvage lymphadenectomy. The very first case worldwide with that intent was done at our place. The first paper was done at our place. So nuclear medicine was part of what we have been doing over the last 20 years. And nowadays it's running, and now in the whole area of theranostics, where we hope that we will be able to start soon. I'm sure that Albi will tell you more about that. But yes, you're totally right. So collaborations is the key.
Because that's the other thing I wanted to pick your brains on, is something that, you know, we took for granted 10 years ago is very different now. And for example, when I first met you, we were just remembering back 16 or 17 years ago, I was at the end of my urology training at Guy's Hospital in London. I remember you came as visiting professor. You had just become editor-in-chief of European Urology. But back in those days, we were doing radical prostatectomy for decent six, exactly, for everyone. Oh, you got cancer. Can I ask you, of the things we do today in 2023, what do you think we might not be doing in 10 years' time? Or if we look back and say, well, I can't believe we did this for prostate cancer.
Well, indeed, I think that radical surgery, which is leaving, unfortunately, a trace in many of our patients, should be abandoned already today for small cancers. And I think that we are on a good trajectory to obtain the target, but unfortunately, at least in these countries, this is not yet the case. While probably in the future, surgery will still be needed to treat bad cancers, and combining different therapeutic modalities will be the key to improve our patients' care. So that is just one example. And if you transfer that into other areas like kidney cancer, for example, more and more we are thinking about and doing percutaneous ablations, and now radiation therapy is coming forward. They will need to be tested with the proof of time, but indeed things are going to change. And this, in a way, if you look well at every single part of our general discipline, there are indeed other areas where we are doing things today that probably will not be done in the future. But in general, I think that we all have been facing a very significant improvement in management of our patients, and they are living longer, they are living better, and everybody's happy.
I'm convinced myself that favourable intermediate risk prostate cancer, especially now we can characterise it much better with MR and better quality biopsies, we'll be able to better select favourable intermediate risk patients that are not going to need at least radical
I agree with you. We have made the decision at our own place after a lot of thinking, a lot of discussing, that we are about to start now with our focal therapy program for prostate cancers, very selected cases. And I would like to change guidelines by having focal therapy no longer an experimental option, but something which is based on very solid things. And so that is one of the many things that we would like to get to, and you are totally right. So management of our patients is changing indeed.
So if we run out of patients to do surgery on, as I think we agree we will, the other big area of change, of course, is in upfront management of metastatic hormone-sensitive prostate cancer, which has been probably one of the most rewarding areas of research you and I have witnessed over the past 10 years, seeing much better survival, et cetera, et cetera. But I think for urologists, we're in the era when the AR pathway inhibitors upfront for metastatic hormone-sensitive disease are becoming more and more available and funded around the world. But I feel that the last 7 or 8 or 9 years, the younger urologists coming through have kind of lost interest in metastatic hormone-sensitive in some respects, because many of those patients went and had docetaxel or they were in trials with our GU medical oncologist. But I strongly believe that the urologists should be very, very interested in these combination approaches, because it's us who diagnose these patients, and these drugs are perfectly, safe to use in a multidisciplinary thing. But what are your thoughts on AR pathway inhibitors and messages for the young urologists listening to this podcast?
I think that urology has always been a discipline, including both surgery and medical therapy. I don't think that every single urologist must be 100% top surgeon. It depends from the interest that everybody of us has. At the end of the day, the whole thing goes, in my opinion, to how much time you have during the day to devote to one special area. Because we should recognize that if we want to be involved in the area of these new medical treatments for prostate cancer, this means that the number of patients that specific urologist is going to face will go up like that. So if that specific person wants to be in that business, my humble opinion is that he or she will be much better than the best medical oncologist, because he has in his hands what is the disease from the very beginning. But then he or she must be extremely well organized to get everything done. So I am totally with you, but it will be difficult to have a very full surgical schedule during your week, and also having the time to take care not only about your surgical patients, if you are following them, because as you well know, unfortunately, many urologists are doing a case and then they have no idea of the results of that specific patient. The patient is gone, and perhaps the urologist is a little bit happy not to know what's going on in the post of surgery. So if you are involved in following the patients, then your days are going to be very full with surgery only. But if you find a balance, then it is absolutely true that these new opportunities with these drugs will change things. And from what I read in papers, now we are talking about drugs, but the lutetium is going to be probably, I'm not saying number one, but used very early in the management of these patients. So a urologist who also wants to be, in a way, a medical oncologist will be extremely busy. There are issues, as you well know, depending on the regulations in every country. So today in Italy, urologists are not authorized to prescribe one of the new hormones. We can prescribe the old hormones, but for whatever reason we cannot prescribe the new ones, and their prescription should come out from multidisciplinary groups making the final decision. So time will tell, but indeed I would not be surprised if in the near future there would be significant change. There are more and more ladies coming in the area in general in Italy, and probably also medical oncology in the Jew area, done by a urologist. A lady urologist would be also perfect for that. So we'll see how it goes.
Well, that was the last question I was going to ask you. Is you have obviously brought through a lot of young urologists over the years, and do you still think urology is an attractive career for young doctors who want a career in surgery or whatever career they want? Can we make sure that we're attracting the best people, including, of course, the best women to come into urology? Is it still an attractive specialty?
I think
what do we do to make it?
It is still a very top specialty. It is top from many different points of view. It is interesting for patient care, for surgery, what we do. I'm thinking about that from our perspective. The return in terms of salaries, of money, private practice, because one also has to think about that. But then, today we are probably seeing another area of discussion which was not so top 15 years ago. How much time want a new urologist, he or she, no difference, how much time they want to devote to their job? Do they want to wake up very early in the morning and go back home late in the evening after a long day of work? Are we sure they do want that? In Italy, I was told a few days ago that last year the residency program in dermatology was the top one in our country. And clearly dermatology is a beautiful discipline. You can do lots of interesting things, but the first thing I would think about dermatology is that no on-calls, no calls in the middle of the night. Probably weekends are free. You do not have an inferior vena cava bleeding all of a sudden. So there will be, urology is indeed attractive for a number of reasons. I hope that there will be many of us in the future, many of the younger students who really will still be very much in the idea of being a part of our future, to do things. But there is no discussion that urology is in the far front of everything. We have robotics and now new robots and endoscopy and then still open surgery, which will remain important in the future, in my opinion, at least in some areas, and then medical therapy. And then the implications of urology, medical oncology, and genetics.
Exactly. And that's what I think one of our trump cards in urology, so broad, so many organs, so many approaches, medical and so on. So I think you're right. I have the same optimism as you, Francesco. Urology will still continue to attract the very best trainees. Thank you very much.
Thank you.
Well, Declan, that was a very eventful trip you had to Milano.
Yeah, it was really enjoyable, Renew, I have to say. I mean, it's nice to be invited to these places, but you learn so much yourself. And the afternoon where all the residents were presenting all of their upcoming work was just amazing. And to see all of the senior team, Monitorsi and Briganti and his faculty critiquing everything. It was coming up to EAU deadlines, actually. So they were preparing all their abstracts, but a superb environment for research. Not just all this super database they have stretching back years and years, but they have a really nice laboratory set up there as well, and really good laboratory leaders in that group. So it's a great place to visit.
I mean, they really are a true powerhouse of research, aren't they? And it's evidenced by all the papers that come out.
And it can be very intimidating for normal humans out there listening to this to say, how can we replicate what they do there? But, listening to Francesco talk about how the team that have worked together to develop all that, that's all doable.
And I think it's also the mindset of wanting to update a system that's been in place for a long time, a well-accepted nomogram that needs to be updated and validated based on new technologies that are coming up and practice that's become standard of care in other parts of the world.
Yeah, it was joyous to hear Giorgio talk about that stuff, because it's very helpful to us, those of us in countries that do a lot of PSMA imaging, to see how can we make sure we're doing our best to select patients to... Because the management impact thing gets talked about a lot. How do we know the decisions we make based on a PET scan will lead to a better outcome for patients? So it constantly gets challenged, especially by the PSMA skeptics. And I think this nice data does help us speak to our patients.
And papers like this are great because it almost immediately translates to a change in practice, doesn't it? I mean, and just the way Giorgio answered your question of, you know, if you saw that patient, no, I wouldn't anymore. And that's quite nice to hear. So if you're ever around Milan, you know, the doors of San Raffaele are always open. They're a wonderful team, so make use of the opportunity to visit.
And thanks very much to them for welcoming us. And that's all we have time for. As ever, please do subscribe, rate, leave a review, whatever you feel generous about. And we'll be back very soon with some more good content coming at you very soon on GUcast. Thank you, everybody.